Now it's a great privilege to introduce pharmacist Obed Aidoo. Obed Aidoo is a board-certified pharmacist from Ghana and a member of the Pharmaceutical Society of Ghana. He has worked as a pharmacist in charge of Sonotech Medical and Diagnostic Center at Accra Ghana. He then worked as a clinical administrator in Lena House Clinic, Tema, Ghana, where he was involved in instituting PBM and bloodless medicine protocols. He was also directly involved in providing patient care, especially to those who wanted to avoid the use of allogeneic blood transfusions. In Ghana, he has been involved in research in bloodless medicine and published in the Ghana Pharmaceutical Journal. He is currently studying for his master's in public health in Torrens University, Australia, with interests in medical research, integration of public health into clinical care, development of strategies and protocols for training healthcare professionals in bloodless medicine and surgery. The title of his presentation today is Bloodless Medicine in Renal Dialysis. Welcome.
Thank you for having me. My name is Obed Aidoo, and I'm presenting on bloodless renal dialysis, the scientific option. Before we talk about renal dialysis, we would like to talk about chronic kidney disease, because in most cases, chronic kidney diseases precedes renal dialysis. So what is chronic kidney disease? It's a clinical syndrome secondary to definitive changes in function and structure of the kidney, and it is characterized by its slow, progressive irreversibility of the change. And there are some predictive tests that could be used in CKD, the urine albumin creatinine ratio test, in which a value of more than 30 milligram per gram is indicative of microalbuminuria, which could be used to predict chronic kidney disease. We also have the urine test, in which proteins identified could be used to predict chronic kidney disease. However, there was a more conclusive test, which is the eGFR, estimated glomerular filtration rates, and we have various stages, as you can see on your screen. And at stage 5, where we have the end-stage kidney failure or renal disease, that is where dialysis is being deployed. Now, in management of CKD, we have the medical management, in which the concomitant diseases like hypertension is managed with our ARBs and ACEs, our diabetes managed with our anti-diabetics. We also have the dialysis stage whilst we are awaiting transplant. But in our part of the world, how many people can afford kidney transplants? And even access to it is a problem. So usually dialysis is a lifelong management, and ultimately the transplant. But in our discussion, we are going to zoom in more on dialysis whilst awaiting transplant. So dialysis is a kidney replacement therapy. Usually it is used temporarily in acute kidney injury, where we are waiting for the kidney function to be restored. And we also use it in end-stage renal disease until the donor comes. But once again, in the context where we are looking at this, access to kidney transplants and even cost is a problem. So it's a lifelong management. We have various types: hemodialysis, peritoneal dialysis, hemodiafiltration, online hemodiafiltration, continuous renal replacement therapy. But in our part of the world, what is common is the hemodialysis and the peritoneal dialysis, and that is what this discussion or presentation would focus more on. So this is a diagram trying to depict the principle in hemodialysis. So we have blood pumped from the patient being monitored, the arterial pressure being monitored. It gets to a point where heparin is injected into the blood to prevent clotting. Then it gets into the dialyzer. In the dialyzer, we have the dialysate, and this is a solution containing water and solutes like magnesium, potassium, and dextrose. So this is hyperosmolar. And there's a continuous flow of the dialysate to maintain the osmotic gradients so as to allow the exchange of solutes from the blood to the dialysate. These solutes are uremic compounds or putative inhibitors. Under normal circumstances, if the kidney is not compromised, they are supposed to be excreted. But once the kidney is compromised, they stay in the system and they become biologically active and cause a lot of troubles, which we would find out later in the discussion. Once the uremic compounds are gotten rid of, the blood filtered and pumped back into the patient. The other type, peritoneal dialysis, it works on infusion and drainage. So we have, once again, the diacylate hyperosmolar being infused in the patient, and it uses the peritoneal lining as the exchange surface, and the uremic compounds are being transferred into the diacylate, and then it outflows out of the body. But before a patient would be put on dialysis, preparation is very key, it's very important. Once again, we said that dialysis is started when the eGFR is below 15. Some school of thought even say plus symptoms. So before the patient gets there, there is the need to prepare the patient psychologically, financially. Again, it's a lifelong treatment. So there's the need for all this preparation. Even medically, there's a need for preparation. In our part of the world, we don't have isolation dialysis. So there's the need for screening the patient for hepatitis and vaccinating the patient. All these take time. So we need to prepare. Even the hemodialysis, research shows that the arteriovenous fistula and the AV graft are better than the normal catheter we use because of infection risks with the normal catheter. So you would need a surgeon to fix the arteriovenous fistula, which is more preferred over AV grafts because of incident of thrombosis with AV grafts. Then the peritoneal dialysis to reuse the Tenkov catheter, which is more comfortable and has low infection risks. Now, the complications of CKD are anemia and thrombocytopenia. These are the areas that are of importance to us today. So we'll be looking at the anemia and thrombocytopenia. How does CKD cause anemia? It is all due to the uremic compounds. These are normally gotten rid of from the body if the kidney is not compromised. And there is one of the uremic compound called hepcidin. High levels of hepcidin affects erythropoiesis, it affects the iron stores, and then we have anemia. And these uremic compounds also affect the functions of platelets. So then we end up having thrombocytopenia in the patients. Now, the effect of dialysis on erythropoiesis is a positive and a negative one as well. The positive aspect is that the uremic compounds are able to be eliminated. That is what is expected to be eliminated from the patient's blood. Once these uremic compounds are being eliminated, then erythropoietin can work well to initiate erythropoiesis. Then the iron stores are not being affected. Once erythropoiesis is maximized, there's also prevention of phagocytosis of the red blood cells, and the inflammation mediators are also gotten rid of by the dialysis. In as much as dialysis promote erythropoiesis, it can also impact on erythropoiesis. Iron deficiency will develop in many dialysis patients as a result of treatment-related blood loss and a high demand for erythropoiesis. So it is very key that patients on dialysis are being monitored and managed for iron deficiency. We should note that sometimes the iron stores would be perfect, very good, but then the circulating ions might not be that good. That is why our TSAT and ferritin tests are important. The TSAT would inform you of the adequate circulating ion, and these circulating ions ensures that erythropoietin therapy is optimized. So we need to make sure that our dialysis is adequate. If our dialysis is not adequate, there's going to be the buildup of hepcidin and other uremic compounds, which would affect erythropoietin therapy, will lead to hypo-responsiveness of our EPO therapy. But what if we check the patient and we find out that the stores, the ion, circulating ions is low? That is when we fall on our Ganzoni formula, where we use the weights, the body weights of the patient in relation to our target HB and the present HB to calculate the amount of iron to give the patient IV. Usually when this is given to the patient IV for over 5 hours, it's prior to administration of our erythropoietin, it optimizes the erythropoietin therapy. So you need to take note of our ion stores as well as the circulating ions. Then thrombocytopenia. Once the dialyzer gets rid of our uremic compound, again, it's the uremic compounds impact on platelet formation. So in effect, it affects for thrombocytopenia. So once they are gotten rid of, then thrombocytopenia would be taken care of. But this same dialyzer can also lead to thrombocytopenia. As in the past, we used to use a dialyzer known as cyprophane membrane, the dialyzer with cyprophane membrane. And these were shown to cause complement activation, leading to thrombocytopenia. But new technologies have evolved, and now we have polysulfone membranes, which are associated with little complement activity. So then platelet thrombocytopenia is reduced with them. And even in them, in using the polysulfone membrane, you realize that there's about 5% decrease in platelets count. So whichever way we look at it, dialysis is important for patients with renal, especially when it comes with managing their anemia and thrombocytopenia. And at the same time, they cause what? Anemia and thrombocytopenia. So that is why bloodless medicine is a key when it comes to manage our patients on dialysis. They need to be monitored and managed well. And in dialysis, there's a low-grade fever, which also impacts on erythropoiesis. So all these point to the fact that there's the need for bloodless medicine in our patients on dialysis. Now, what some clinicians do is that they infuse allogeneic blood transfusion, or they prefer allogeneic blood transfusion. But in a research, landmark research here in Western Australia, Leahy et al. 2017, it clearly shows that allogeneic blood transfusion is associated with increased mortality, increased morbidity, increased hospital stay. But implementation of patient blood management is associated with improved patient outcome, and it's also cost effective. The problems with allogeneic blood transfusion are a lot. We have dilutional thrombocytopenia, infection complication. already. The patient has low-grade infection. So if you infuse blood transfusion, which are, if you infuse allogeneic blood, which are infective, then it is going to worsen the patient's condition. Then we have the non-infectious complication, the Trali-Taco, hyperkalemia, iron overload. Now, our bloodless medicine strategy, one of the key things we have to put in place is to prevent iatrogenic blood loss. So we encourage micro-sampling. I think yesterday, the doctor from Johns Hopkins spoke extensively about this, and realized that even experienced doctors back in Ghana make these mistakes, and it affects the patient. So micro sampling should be encouraged in management of patients on dialysis. Even with all our patients who are anemic, micro sampling very important. And anemia management of CKD should include our erythropoietin ion. We shouldn't forget our circulating ions. Make sure there are enough circulating ion, vitamin B, folic acid. And nutrition is very important. Nutrition is very important. So we should include the dietitian in the management of patients on dialysis. With the platelets, we have our thrombopoietin receptor agonist. We have our recombinant human thrombopoietin. Treating of our infection, we shouldn't forget our broad spectrum antibiotic. We are also saying that research shows that the AVF and the AVJ are better because they have low infection rates compared to the normal catheters we use. Then our dialyzer membrane, you would want to use the polysulfones instead of the cyclophones. So our recommendations are that we should avoid the wait and see approach when we care for our CKD patients. We should improve medicine availability should be improved. Now, medicine is shifting towards a multidisciplinary approach. So this is not a one-man show. All other healthcare professionals should be brought on board, especially even the nutritionist has a role to play. So we need to do that and avoid use of catheters. We need to train more specialists in renal treatment, especially pharmacists, nurses, physicians, and we should develop local solutions for local problems. These are my references. Thank you very much.